Hello friends, welcome to my YouTube channel Oncology for Residents. Today we are going to continue with our series of lectures on imaging for oral cancer. Before we begin, for those who are new to this channel, I am Dr. Parveen Ahlawat. I am a consultant at Rajiv Gandhi Cancer Institute and Research Center in New Delhi over 12 years, and I have been practicing and teaching oncology for more than a decade. I completed my MBBS and DMRT from CMC Vellore, did my DNB at Rajiv Gandhi Cancer Institute, pursued a fellowship at Royal Marsden Hospital in London, and I have later undergone specialized training in cyberknife from the United States. We divided entire topic of oral cancer imaging into 4 parts. We completed part 1 in our previous video, which contains basics of CT and MRI. Today, we are going to discuss second part, imaging for centralized structures such as tongue. These are the MRI sequences for head and neck oncology I showed you in my previous video. I am not going to go through this again. You must go through with my previous video on basics of CT and MRI if you have not watched it yet. That video is the foundation for reading MRI. Now let's get to this topic. Imagine you get an oral cancer case in your exams and your examiner asks you which local imaging modality will you order for your patients. Suppose you get one of these patients. There is a tongue, upper gingiva, hard palate, lower gingiva buccal complex cancer. Now you have 3 choices: CCT, MRI or PET CT. Which imaging will you choose for your patient? Most residents will just pick their own favorite modality or will pick up something their bosses have been choosing for their patients. Stop doing it. Trust me, if you just pick one scan for all patients of oral cancer, you are going to be wrong half the time. So how should we choose the best imaging for a particular patient of oral cancer? The correct answer is, sir, before I select a best imaging for my patient, I want to look at 2 specific parameters, 2 specific questions. First question, what is the primary site of tumor of my patient? Whether it is a central disease in the oral cavity, that means tongue or floor of mouth, or is it a lateralized tumor, also called as vestibular space tumors such as buccal mucosa, gingiva, gingivobuccal sulcus or retromolar trigone. Second question, what are you suspecting in this patient based on history and oral examination? Are you suspecting bone involvement that will change your T stage and change your surgical plans? Or are you worried about whether a nerve is involved? When your patient says he feels numbness or paresthesia or some part of his face. If you ignore these 2 questions and order a scan randomly, CT or MRI or PET CT, you are just guessing. And we don't guess in oncology. So let us dive into the first factor which will decide the imaging modality we will choose. What is the site of primary tumor in a patient? Let us start with the imaging for centralized tumors such as oral tongue. Everything we will discuss about imaging for oral tongue is also applicable for floor of mouth. These are the 3 parameters which need to be studied when we talk about imaging for oral cancer. Number 1. Soft tissue visualization of tumor. 2. Measurement of depth of invasion. 3. Assessment of neurovascular bundle involvement. Any MRI report should have these 3 factors described in detail. Let us first discuss the soft tissue visualization. Look at these 4 images on your screen. Take a moment to appreciate the clinical variation here. we are looking at tongue cancer in 4 completely different patients. The first image on the top left shows a very superficial ulcer confined to the lateral border of tongue. The second one shows a similar but slightly larger superficial ulcer. The third image demonstrates a frank ulceroproliferative growth. And the fourth is a massive, very large ulceroproliferative tumor replacing a significant portion of the tongue. Now, the first and most fundamental step in the clinic is always a thorough clinical examination. But we have a major limitation with clinical examination. Clinical palpation alone cannot accurately determine the deeper extent of these growths. For that precise deep tissue mapping, we are entirely dependent on high quality local imaging. What exactly are we looking for on these scans? We need to pinpoint the exact epicenter of the primary tumor. Whether it is a lateral border of tongue, dorsal surface of tongue, ventral surface of tongue, or tip of the tongue. We need to measure the precise size of primary tumor in all 3 dimensions for accurate AJCC T-staging. We absolutely must calculate the exact depth of invasion or DOI because that directly dictates our T-stage and the need for elective neck dissection. We need to evaluate whether the deep intrinsic or extrinsic muscles or the floor of mouth are involved or not. We have to check if the tumor is extending up to or frankly across the midline. How far is the advancing edge of primary tumor from the lingual septum? Is it merely abutting septum or is it physically pushing or crossing it? You must see the sublingual space to see if the neurovascular bundles are involved. Also, we must trace the exact posterior extent of primary tumor, tracking the tumor towards the base of tongue, the vallecula, down to the hyoid bone. We need to see if there is any signs of perineural spread along the major nerves in the tongue. If the tumor is large and abutting the lingual surface of gingiva, we need to rule out if there is a cortical erosion of gingival surface of mandible and mandibular marrow involvement. Listen carefully. If you miss even one of these parameters, your radiological interpretation is completely inadequate for surgical planning. So ask yourself a very practical question. Which imaging modality shows the superior soft tissue contrast required to give us all these information in detail? CT or MRI? Look at the tumor of this patient. This patient presented with a left lateral border tongue lesion on inspection and palpation. First, look at the contrast CT of this patient. Many of you, especially beginners, cannot even make out on the CT exactly where the lesion is, let alone mapping out its detail. The soft tissue resolution is simply poor in CT scan. Look closely at the tongue and the floor of mouth. The tumor densely blends almost seamlessly with the normal tongue musculature. The margins are completely indistinct. So ask yourself, how are you going to confidently delineate the tumor border here to ensure adequate surgical margins? How are you going to measure a precise depth of invasion for accurate AJCC staging? You can't. Now, look at the MRI of this patient. The difference is huge. Now the tumor has lit up like a bulb. You can clearly see a sharp, very well-defined enhancing tumor on the left lateral border of tongue. The contrast between the tumor and the normal intrinsic musculature is excellent. You can see the edges of the lesion all around very clearly. Because of this clarity, you can even measure the depth of invasion down to the millimeter. You can clearly identify the midline septum in coronal section and see exactly how close the tumor is. You can confidently assess the genioglossus, the hypoglossum, and other deep muscles. You can even reliably assess the neurovascular bundles. The bottom line for you is this. If you need to evaluate the extension of an oral tongue carcinoma in detail and with absolute certainty, MRI is the imaging of choice, not CT scan. CT simply won't give you the details you need. Let me give you another example to show why MRI is better than CT for tongue cancer. This patient has a small superficial ulcerative lesion over the right lateral border of tongue. See his CCT image. Beginners like you might not even find anything in his tongue, right? It looks almost completely normal. However, when I show you his MRI image on the right, the picture changes completely. Suddenly, you clearly see an enhancing lesion in the right lateral border tongue. It lights up like a bulb. Now you can properly assess all the parameters I showed you in the previous slide to accurately plan his surgery or radiation. So mark my word, the imaging of choice for a tongue cancer is always MRI. Do not say CT scan in your exam. The only time you should order a CT scan is if there is no MRI facility available in your center or in your city, which is rare these days, or if there is a severe cost issue for the patient, or when there is a very long waiting list for MRI. Otherwise, you must get an MRI done. Although a CT scan can show some features of a very large lesion, the fine details of the exact tumor extent can only be made out on an MRI. Why? Because MRI is the king of soft tissues. MRI shows the soft tissue beautifully well. So henceforth, if you get a tongue cancer case in your practical exams, your answer for imaging of choice should be always contrast enhanced MRI. We have established that MRI is mandatory for tongue lesion. Now look at these 8 different patients on your screen to understand exactly why. All these 8 patients have their primary tumor in the left lateral border of tongue, but the extent of disease is very different. They are arranged in increasing order of size. We start with a small early lesion on top left and advance to a massive destructive lesion on the bottom right. Look at the clear differences between the bright white tumor and the dark normal tongue muscles. This is what we mean by superior soft tissue resolution. Because of this clarity, we are not guessing. We can exactly pinpoint the center of primary lesion. For accurate AJCC T staging, you need absolute precision. On these MRI scans, we can measure the exact size in all 3 dimensions. Most importantly, we can calculate the exact depth of invasion down to the millimeter. As you move from top row down to bottom row, notice how the tumor spreads locally. With an MRI, you can confidently report if the deep extrinsic muscles like the genioglossus and hypoglossous or floor of mouth are involved or not. You can clearly identify the midline lingual septum. You can definitely tell whether the tumor is just touching it, pushing it, or completely crossing it like you see in the bottom right image. You can also check the lingual neurovascular bundle to see if they are displaced or invaded. Finally, we can accurately trace how far back the tumor has gone. We can see its exact relationship to the base of tongue, valvula and the hyoid bone. You need this exact mapping of primary tumor in tongue for accurate staging, surgical planning and radiotherapy planning. This level of detail is simply not possible with a CT scan. Now all these detailed information about the lesion will impact your surgical plan also. What type of surgical excision will all these 8 patients require? Let us break it down. Patient 1, top left. There is a small superficial lesion confined to the extreme left lateral border. The depth of invasion is minimal. He will likely just require a wide local excision or partial glossectomy. Your primary goal here is achieving clear margins while saving as much tongue volume and function as possible. Patient 2 still has a superficial left lateral border lesion. He will also be managed very well with a partial glossectomy. Patient 3, top middle. This is a large and deeper lesion, but it remains lateralized. Notice there is a clear space of fat between the tumor and the midline lingual septum. He will likely require a wide partial glossectomy or a hemiglossectomy. If the surgeon can get a safe 1 cm deep margin without cutting the septum, a wide partial glossectomy will work. Otherwise, a proper hemiglossectomy is needed. Patient 4 on top right, this is a deeply infiltrating tumor. It replaces a large part of left tongue muscles and goes deep towards the root, but it does not cross the midline. He will require a hemiglossectomy. The surgeon will remove the entire left half of the tongue using the lingual septum as the medial surgical boundary. Patient 5, a large left lateral border lesion seen here in the coronal view. It involves the entire thickness of tongue. The tumor reaches the lingual septum and is slightly pushing it, but it shows no signs of infiltrating or crossing the septum. Patient 6, bottom left. Now we see a bulky tumor expanding the left half of the tongue and it is severely pushing against the midline septum. He will likely require an extended hemiglossectomy. Why? Because the surgeon needs to have 1 cm safe margin. So they must cut past the midline septum and into the normal muscles of right side of tongue to ensure no tumor is left behind. Patient 7, bottom middle. He has a massive tumor that frankly crosses the midline septum anteriorly. It involves the deep muscles and the floor of mouth. He will require a subtotal glossectomy. The surgeon will remove the entire left half and a big portion of right half of tongue along with the involved floor of mouth. A free flap reconstruction like an anterolateral thigh flap is absolutely mandatory here to restore function. Patient 8, bottom right. He has a massive, highly destructive tumor replacing almost the entire front 2/3 of the tongue. It extensively crosses the midline and goes far back toward the base of tongue. Both neurovascular bundles are likely compromised. This requires a massive resection and a bulky free flap just to prevent aspiration and restore volume. Functional outcome for speech and swallowing will be severely impacted in this patient. Not only above surgical plan change, radiation plan will also be altered as your GTV and CTV will change accordingly. In summary, the entire surgical and radiation plan for these patients completely depend on this level of soft tissue detail. Without a high quality MRI, accurate T-staging and exact and detailed tumor mapping is simply not possible. So this is all about the soft tissue visualization of tongue carcinoma. Let us move to next parameter we need to check in tongue cancer. Let us move on to another major advantage of MRI in evaluating oral cancer. MRI is an excellent tool to measure depth of invasion. Let us see details of it. As you all know, the 8th edition of AJCC Cancer Staging Manual introduced depth of invasion based T stage. It now strictly mandates a precise measurement of the clinical depth of invasion or DOI to assign an accurate T staging. Now, residents often ask me, sir, why can't I just order a standard contrast CT? The big limitation with CT scan is that they frequently fail to clearly define that crucial deep margin. Why? Frankly speaking, a CT scan simply has very poor soft tissue contrast in this area. Also, often dental artifacts heavily scatter the image. And I showed you CT images of tongue cancer a few minutes ago. They look so poor for tongue cancer. Let us take a practical example. This is the patient with a lateral border tongue carcinoma. We need to measure his depth of invasion. If you only order the CT scan for this patient, you might not be able to locate the exact deep margin of the lesion. But we did an MRI for him. Look at the scan. See how nicely the tumor is enhancing. The clear depth is beautifully visible now. Notice how MRI offers superior contrast resolution. It allows us to confidently map the exact tumor boundaries against the normal intrinsic muscles of the tongue. So the takeaway is simple. When it comes to accurately measuring the depth of invasion, no other imaging can beat MRI. So how exactly do we calculate the vertical depth once we have the MRI scan in our hands? Let us look at the exact mechanics of measurement on this next slide. By definition, depth of invasion is measured specifically as the vertical distance between the deepest point of tumor infiltration and the simulated normal mucosal junction. Simulated normal mucosal junction. Look at the green line on the scan. This is your reference line. It represents that simulated normal mucosal plane, essentially where the normal mucosa would be if the tumor was not there. You can see the surface dimension along that green line is 4.8 centimeter. But listen, the critical number for your staging is the red line. You drop this red line as a perpendicular vector from your green reference line straight down to the deepest point of tumor infiltration. Here, that exact depth is 2.6 centimeter. I want to stress this to all of you. Achieving this level of measurement accuracy confidently is really only possible with MRI. When you are planning a surgical resection in a bag of muscles like the tongue, this perpendicular measurement dictates your surgical margins and directly tells you the risk of metastasis to the lymph nodes. So always rely on precision of MRI. Now some of you might be a little confused here. You might ask, sir, depth of invasion is a pathological term. It is meant to be measured on microscopy. Why are we measuring it on MRI? See, the 8th edition of AJCC Cancer Staging Manual clearly mandates that we need to assess this clinically for our T staging. And let me assure you that there are multiple robust studies which have found an excellent correlation between MRI measured depth of invasion and microscopy measured depth of invasion. So it is highly reasonable to say that whatever depth of invasion I am measuring on this MRI will be found very similar to the final histopathology report. Let me show you two more cases of how you measure depth of invasion. This is a case of right lateral border tongue. Measure this distance. This is depth of invasion. This is a case of right buccal mucosa and this is the depth of invasion. So this is all about depth of invasion I want you to learn at this stage. Let us move to next parameter which we need to see in all tongue cancer. See, another big advantage of doing MRI. MRI is an excellent tool to detect neurovascular bundle involvement by the tumor. Let us see the details of it. The next big clinical challenge is figuring out exactly what is happening to the nerves and blood vessels deep inside the tongue. As a treating surgeon, you absolutely need to know, is the tumor just pushing neurovascular bundles aside, or are they actually involved or completely encased by the tumor? This dictates whether you might need to perform a massive surgery like a total glossectomy. Now, you might be tempted to just check a standard CT scan to find out. But here is the practical limitation. CT scans simply fail to differentiate complex soft tissue structure down in the floor of mouth. The soft tissue contrast just is not there, and everything tends to blend together into one gray mass. If you rely solely on CT scan, nerve involvement is often left completely ambiguous. You are basically asking your radiologist to make an educated guess. The solution is very straightforward. You need to order an MRI, not CT scan. Please do not make your radiologist struggle with a CT scan, troubling him to comment on neurovascular bundles involvement by tongue cancer. MRI gives you the superior contrast resolution required to clearly visualize both the neurovascular bundles and the entire sublingual space. So the rule is simple. If you want a precise stage and you need to know if those critical nerves are involved before you plan your treatment, always go with MRI. Before I go on to show you the involvement of neurovascular bundles by the tongue tumor, let me show you some normal anatomy of sublingual space. The neurovascular bundle of tongue is not a random collection of vessels. It is a highly structured and has predictable pathway. It contains three critical structures: the lingual artery and its vein, the hypoglossal nerve, which is cranial nerve 12th, and the lingual nerve, which is a branch of V3. To understand how a tumor invades these structures, you must memorize one absolute landmark, absolute muscular landmark, the hyoglossus muscle. Imagine the hyoglossus muscle as a vertical wall dividing the tongue. The structures of the neurovascular bundle travel on either side of this wall. Always remember, the lingual artery courses medial to the hypoglossal muscle. Lingual artery courses medial to the hypoglossal muscle. It runs deeper, close to the midline. The nerves, both the hypoglossal nerve and the lingual nerve, course lateral to the hyoglossus muscle. They run in the superficial plane of sublingual space. Why do we need to know this arrangement or sequence? Because on a standard MRI, especially when the anatomy is distorted by a massive tumor or severe dental artifacts, you will almost never see these nerves clearly. They are simply too small to be visualized on any imaging. But you will always see the lingual artery clearly. It is a prominent, easily identifiable landmark on a T2 stir sequence. Therefore, we use the lingual artery as our definitive radiological surrogate. This brings us to the absolute clinical rule of neurovascular bundle. Listen carefully. The nerves are always lateral to the artery. If you see an oral tongue squamous cell carcinoma invading sublingual space and that tumor physically obliterates that tissue plane strictly lateral to lingual artery, you must assume the hypoglossal and lingual nerves are compromised. You do not wait to see gross macroscopic thickening of the nerve. If the space is obliterated, the nerve is most likely involved. See in this image. The arrangement is lingual artery in red is medial most and nerves in yellow are lateral most. If there is a tumor in lateral border of tongue, it first has to involve nerves before the artery. So if artery is involved, assume it that nerve is also involved. Let us look at exactly how we see this on MRI using a real patient example. This image shows a coronal stir MRI sequence showing the tumor invading sublingual space lateral to this lingual artery, suggesting invasion of lingual and hypoglossal nerves which are located lateral to the artery. You can see artery here. This image shows a very large tongue lesion involving both lingual arteries. This specific level of anatomical detail is exactly why you must order an MRI, not a standard CT. MRI clearly shows us this critical arterial landmark and the soft tissues of the sublingual space. This is a massive decision point because if you find that both neurovascular bundles are involved, your surgical plan changes drastically as the patient will now require a highly morbid total glossectomy. With this, we finish now our discussion on imaging for tongue cancer. We see how important is MRI for evaluating tongue cancer. Every information we need to know about the tongue lesion can only be accurately checked on MRI, not CT scan. My next video is going to be on imaging for lateralized tumors such as buccal mucosa, gingiva, GB sulcus and retromolar trigon. There we will see how CT scan has a major advantage over MRI. Stay tuned. Signing off, Parveen, Ahlawat.